Hello, my name is Miller Killgore, and my research question is how does constraint-induced movement therapy improve upper extremity function for children with cerebral palsy? Children with a diagnosis of cerebral palsy are subject to developing compensatory strategies in order to function only by using the unaffected arm. Constraint-induced movement therapy is a therapy intervention approach that involves harmless restraining of the unaffected arm in hopes of promoting strength, movement, and use of the affected arm to complete daily tasks in a child's life. The four articles that I chose to do my research caps and cat on for this term support the claim that constraint induced movement therapy improves daily functional mobility of the affected upper extremity and quality of life of children with spastic hemiplegic cerebral palsy. The sample size in all four articles was small due to the strict inclusion criteria. The gold standard assessment of the assisting hand assessment and the quality of upper extremity skills tests were only used in one of the four articles, resulting in a limitation. All of the articles were randomized control trials, giving this study good quality research to back up the positive effects of CIMT. And there were control groups in three of the four studies. Throughout my search on constraint induced movement therapy to treat pediatric cerebral palsy, I have found that there is a somewhat small amount of research on this topic. Specifically, there is research regarding constraint induced movement therapy, and there is research encompassing cerebral palsy, but there is a gap in the research of the two topics together. I will begin by discussing study number 1. Children aged 6 through 12 and diagnosed with congenital unilateral spastic cerebral palsy were selected through a convenience sample to participate in this study. The intervention group incorporated principles of shaping the affected upper extremity and repetitive task practice while wearing an elastic bandage and restraint mitten on the unaffected upper extremity. The control group participated in standard occupational therapy with unilateral and bilateral rehab. The outcome measures that were used in this study were the Bruinix-Ostretsky test of motor proficiency, the functional independence measure, the kinematic analysis, and the Peabody developmental motor scale. The Bruinix-Ostretsky test of motor proficiency, the functional independence measure, and the Peabody developmental motor scale all showed statistical significance in the intervention groups, whereas the kinematic analysis showed improvements in both intervention and control groups. The second study has children ages 7 months to 96 months who were diagnosed with hemiplegic cerebral palsy were chosen for the study through convenience sampling. The participants in this intervention group had their unaffected upper extremity casted and restricted as the child participated in reaching, grasping, weight bearing, and manipulating objects with the affected upper extremity. The control group participated in conventional therapy. The outcome measures used in this study were the emerging behavior scales, the pediatric motor activity log, and the toddler arm use test. The emerging behavior scale reported a significant improvement in motor patterns and functional activities. The pediatric motor activity log showed no significant difference between the intervention and control groups, and the toddler arm use test showed a statistically significant difference in the intervention and control groups. The third study had children ages 6 months to 6 years who were diagnosed with spastic hemiplegic cerebral palsy were recruited for the study through convenient sampling. Children in the intervention group were customized hand and wrist splints and slings on their affected upper extremity. Once the splint had been on the child's unaffected arm for the allotted time period, it was removed and the child participated in bimanual activities. Children in the control group received traditional occupational therapy services. The outcome measures used in the study were the Jepson-Taylor hand function and the Pediatric Evaluation of Disability Inventory. There were no significant differences in the Jepson-Taylor hand function. There was a significant difference in functional skills when the Pediatric Evaluation of Disability Inventory was conducted. The last study had children between the ages of 3 and 6 years of age who were diagnosed with cerebral palsy. Individuals were divided into two intervention groups. One participated in CIMT for 3 hours, and the other group participated in a therapy session for 6 hours. The children's unaffected upper extremities were restrained while performing repetitive motor patterns such as manipulating objects, reaching, and grasping with the affected upper extremity. There was no control group for this study. Outcome measures were the assisting hand assessment, pediatric motor activity log, and the quality of upper extremity skills test. Both the assisting hand assessment and the quality of upper extremity skills test showed significant improvements in the intervention group. The pediatric motor activity log also recorded significant improvements as well. Implications for practice, education, and future research. The studies that have been conducted on the effects of constraint induced movement therapy to treat children with cerebral palsy are important for occupational therapists to have as evidence to back their practice. Because this therapy approach has been proven to be effective, occupational therapists can utilize constraint induced movement therapy as well as traditional occupational therapy services in the clinic to improve upper extremity function in children who are diagnosed with cerebral palsy. The implications of constraint-induced movement therapy applies to occupational therapy practice in the sense that the tangible and substantial evidence found in these articles supports the use of the therapy technique and provides occupational therapists with the knowledge of how to demonstrate and perform this kind of therapy.